To this excellent academic program. My topic, role of primary hemiarthroplasty and THR in IT fractures. I must say at the outset, the role is not very great. But a definite set of people who will get benefited with arthroplasty as a primary procedure in cases of intertrochanteric fractures. We know intertrochanteric fractures, they take place in the part of the bone which is very cancellous and highly vascular. That's why majority of the time can be managed successfully with internal fixation, achieving osteosynthesis. That's why the need for arthroplasty is not very great. Here, the mainly mechanical problem. If you can restore mechanical stability to the fractured bone, it is going to be successfully united. But there are situations where your mechanical fixation devices might not be able to hold the fragments in position, in which case probably arthroplasty will definitely come into picture. So what are the indications for arthroplasty in IT fractures? Already has been a lot said about these unstable fractures in the elderly people, of course, but all unstable fractures need not go for an arthroplasty. Nowadays, the PFN is being chosen as the implant of choice for unstable intertrochanteric fractures. Before the popularity of PFN, I used to do a lot of bipolar surgeries, cemented bipolar for these unstable intertrochanteric fractures. But when the PFN became popular, in the last, I must say, 6-7 years, the number of bipolars I have been doing has come down drastically. But once in a while, there is a patient where definitely there is a role for cemented bipolar arthroplasty. So the situation is where the bones are broken into multiple fragments. When the bone is very osteoporotic, you have to think of an arthroplasty in an elderly patient. Similarly, if there is a pathology, particularly in the periacetabular area or in the femoral head and neck, then you may have to go for it. If it is confined to the pathology is confined to the femur only, probably you will get away with a bipolar arthroplasty. If the acetabulum also is affected, then you have to think of a total hip replacement. That is the only indication for a total hip replacement in the case of unstable intertrochanteric fractures, associated pathology. So this slide, even though it is not directly related to my talk, I would like to mention a bit about it. Failed IT fracture fixations, then definitely there is a role for arthroplasty, either bipolar or a total hip replacement. It's a good Salvage procedure. If internal fixation fails, then primary arthroplasty for IT fractures, what are the advantages? If you do an arthroplasty in the type of patients which I have told just now, the advantages are good pain relief. Patient will be very comfortable the moment you put in the prosthesis. Early weight bearing is possible, and faster rehabilitation also is always there. But there are some difficulties in executing the arthroplasty. The problem of stem fixation in the presence of severe osteoporosis. We know DORS classification, type 3, there won't be any bone stock, then you have to think what type of fixation will give you the stability. Getting vertical and horizontal offsets right. This is also very important in the situation of intertrochanteric fractures, because if your offsets are not right, their soft tissue balancing is not there, and then they can go for dislocations. Similarly, version. Perfect version is very important in these situations. If you go deviate a little more than what is acceptable, then you stand the risk of dislocations. And similarly, abductor restoration is a definite problem. If you don't restore the abductors, then the chance of dislocation are there, and the patient can have tendon vertigo. What are the other perioperative problems? Surgery is a bit prolonged in comparison with your internal fixation devices, technically demanding, at least in the beginning. Blood loss, there was some discussion earlier, but I feel definitely if you do a bipolar, the blood loss may be more than with your PFN type of fixations, and embolic manifestations, because you are going to use cement in this case. If not in all the cases, once in a while there is a risk of embolism. You have to be aware of these possibilities. So what are the other possible complications? Postoperatively, dislocation is always there, so you have to keep that in mind in the management of these fractures. Trochanter non-union and abductor insufficiency. Limb length discrepancy also if the surgical technique is not properly executed. And acetabular erosion, I must say a point about this particular thing. It is not that great actually. Whether you do unipolar or bipolar, acetabular erosion is not in the literature also the percentage of erosions will be just 2 to 4%, I think. That's not very great. So it need not be a concern at all. Key steps in arthroplasty, the selection of the process is important, and literature says always call calcar replacements, but we have been using without calcar replacement. Long stems, particularly when you have subtrochanteric extensions of the fractures. Modular implants will be always beneficial because you can exchange that into a total hip replacement if the patient outlives than what you expected, or on the table also sometimes if you have a modular implant, you have fixed the stem and you feel that the soft tissue is not tight enough, you can go for increased neck length. So modular always helps the surgeon technically and also in the long run. And if you are doing a THR in these cases, which is very rare, you have to think of using larger heads, and constrained liners also must be available because the chance of dislocation could be there. Key steps further, offset inversion, very important. Reduced trochanter will guide the vertical seating of the process. In bipolar, if you are doing for an intertrochanteric fracture, bipolar or THR, you don't have any local anatomy, everything is disturbed. Then how to judge the insertion depth of the process? This is easily can be arrived at by reducing the fracture. As soon as you open the fracture area, reduce the fracture and measure the distance from the tip of the trochanter, fracture trochanter, to the intact proximal end of the distal fragment, that is the shaft fragment. Keep that distance in mind. It may be 2 centimeters or 15 millimeters or whatever. This will help you in seating the process towards the insertion. And axis of the leg will guide you the version. Because local anatomy is not there, you have to go for indirect techniques of arriving at these points. Stem fixation, cement stems are chosen, very rarely uncemented, because most of these people will have osteoporosis. It's always better to go for cemented stems. Cementing technique, as I said earlier in the discussion part, I always choose manual insertion because these elderly people are having cardiopulmonary problems many a times, comorbidities. If you go blindly for second generation, third generation insertion of the cement, you might produce complications, pulmonary complications. But that's why I always go for manual cementing. The cement will be in a doughy state. The monomer is not there. Already it is polymerized. So a very little monomer. The question of you having these hypotensive episodes, I have not seen so far. That's why I never think of pressurization in these cases. Trochanter fixation, the tension band wiring, screws, rarely plates. If the trochanter fragment is quite good, if it has taken a chunk of bone, this shaft part, you can use a plate as it has been shown in the diagram, or you can use tension band wiring with screws. That's what I regularly do for most of my bipolars. And if it's a very elderly patient where the life expectancy is not great, you can use cement also to achieve stability of the trochanter. Doesn't matter. Put cement, let the fragment sit, and then use 2 screws and a tension band. That should work. Role of primary THR, not indicated. First of all, I must say strongly about this. Don't think of a THR as a primary procedure for intertrochanteric fractures, because these people are very elderly, they are not active, hemi will suffice. In group of patients relatively young and longer life expectancy, in which case you can think of a modular bipolar which can be converted into a THR if the patient outlives. Acetabular erosion is not a common problem, so that should not affect your decision. Role of primary THR again is not there because the procedure itself in an emergency situation can be dangerous. Extensive surgery in the emergency situation, lot of comorbidities. When it is not indicated, you don't undertake this procedure, which could be dangerous, and the patient can die also sometimes. Similarly, the postoperative complication must be kept in mind in choosing the procedure. Dislocation rate is very high if you do a THR. That is why better not to think of a THR as a primary procedure. If at all, in rare situation, if you want to do a THR, think of larger heads and keep constrained liners also on the table, as I already said. Role of primary THR, rare indications, as I said, IT fractures with arthritic hip or periacetabular pathology, in which case you have no choice but to go for a total hip replacement by taking all the precautions which have highlighted. Some of the studies here, there is not much structured, say, literature here, well-designed, structured literature available for us, but there are some case series presentations which favorably say about hemiarthroplasty for unstable intertrochanteric fractures for elderly people. So these are some of them. Role of bipolar, coming to the bipolar THR, there is no evidence at all to support. For bipolar, is indicated in a select group of patients where internal fixation may fail. Elderly, as I said, severely osteoporotic gross comminution, particularly where the lateral wall of the trochanter is exploded, as Dr. Srikanth was pointing out. The lateral trochanteric buttress, if it is not there, even your PFN is not going to help, in which case probably arthroplasty will be useful in this particular group of patients. When there is pathology in the proximal femur, along with that IT fracture, then obviously this is one of the procedures of choice. And for a hemiarthroplasty, the acetabulum should be reasonably healthy. This, as I said, some of the studies, I'm not going to go into the details, all of them, they are not well-structured ones, but they say favorably about a cemented bipolar arthroplasty in cases of intertrochanteric fractures which take place in very elderly with osteoporotic bones. I will not go into those details. Coming to the summary, role of THR, no role for primary THR in IT fracture management except in rare situations, high complication rate. When indicated, you have to think of larger heads. I'm talking about this again and again. Larger heads and constrained liners may be useful. Regarding bipolar indicated for select group of patients, literature support is weak. Early pain-free weight bearing and faster rehabilitation are possible. Trochanter non-union is a problem which has to be kept in mind. Calcar replacement and long stems may be needed. So thank you as far as that talk is concerned. I will continue with my next one, which is related to this only. Can you please? This? Yeah. Just fine. So just I will take you through. This is one of my patients who I did quite some time ago, and I hope that this will be useful to know a little about what I do. 91-year female, aided walking before the fall. She had a comminuted intertrochanteric fracture. So this is how we prepare the hips, any hip surgery, this is how we drape. Very important because infections need to be eliminated. So most of the money that is spent in the operation theater is to eliminate the risk of infection. So you have to take all the precautions. Surface markings, for particularly the juniors, I must say, surface anatomy marking is very important. If you deviate with your incision even 1 centimeter this way or that way, you will have hell of a time in going to the deeper levels of your working area. So surface anatomy, mark that, and accordingly choose the incision. Skin incision, and then you come to the fasciolata, which can be incised. Then you get the trochanteric bursa, which will be contused, excise the trochanteric bursa. Then abductors. So partially, always I try to preserve the posterior 2/3 of the gluteus medius, anterior 1/3 I take it away. So here also this is a modified Harding's approach, which you are observing now, and you expose the neck. This is the same like what you do for your intracapsular fracture as far as this is concerned. And I do the neck osteotomy. Here you have an intertrochanteric fracture situation, so if you want to extract the head and neck broken part, very difficult. So you have to go for a subcapital osteotomy first. Do a subcapital osteotomy and then take away the intervening bone, which is mainly the calcar part, broken calcar. And then it will be easy for you to take away the head. That is what is shown in the next diagram, extraction of the head. Now, plan for axial seating. As I said already, you don't have the local bony anatomy, so you have to depend on an imaginary point. How to arrive at the imaginary point means, as soon as you expose a fracture like this, reduce all the fragments, reconstruct the femur, and see where the top of the trochanter is in relation to the intact bone. Take that measurement, keep that in mind. Now, you have seen the preoperatively the sound hip. Sound hip, you have to see the relationship, as I already said, the top of the greater trochanter, relation between the top of the greater trochanter and the femoral head on the other side, intact side. That need to be kept in mind. Now you have to recreate here. The prosthetic head center should be in relationship to the top of the trochanter, which is now an imaginary point because it is broken. So reduce the fragment into an anatomical position, take the measurement from the top of the broken trochanter to the intact bone. That will guide you in the axial insertion of the prosthesis. Now, canal finding. This is one important step in osteoporotic bones. When the cortex is very thin, particularly in obese patients, if you don't see this and insert your rasp, you can perforate. I have seen things happening, the stem going either medially or outward, perforating this. So use a simple straight instrument like this and push it so that you know the direction of the femur shaft. Then you can safely insert your rasp. Before you go for rasping, I would like to say, put the suction tube and take away all the loose tissue. That will minimize the risk of embolic manifestations. in these elderly people, either it is intracapsular or extracapsular hemi or whatever you are doing, unless you are doing uncemented, if it is a cementing one, use this suction catheter to suck away all the loose tissue from the marrow area so that embolic manifestations can be minimized. So that is very important before you introduce the RASP. Now rasping, as I said, the version is very important. If your version is not correct, it is going to go for a dislocation. I must tell again for the juniors, in the anterior approach, anterolateral Harding's approach, you should not have too much of anteversion. If you have too much of anteversion, it will dislocate anteriorly. In the posterior approach, you can have up to 20 degrees of anteversion, whereas in the anterolateral approach, it should be 0 to 10. See, if you see, observe this one, the long axis of the Tommy bar, which is here, should be in line with the leg first. That gives you 0 version. Over that, you can tilt it to the extent you need, and as I said, in the anterolateral approach, it should not be more than 10 degrees. So that is what is shown here. The Tommy bar is guided by the long axis of the leg. Whichever position it is, this is one indirect way of arriving at correct version. Don't bother about the local anatomy, whether you are in the supine position or lateral position, whatever it is, the knee will be usually flexing. This is the long axis, and the Tommy bar that is sitting in the RASP should be in line. That gives you 0 version. Based on that, you can increase or decrease your version to the requirements. Now here you see, unlike your intracapsular fracture, in IC fracture you are going to lose part of the bone, proximally the metaphyseal bone. Here I have put a mark here. That is the amount of bone that you are going to lose. To that extent, you will have a gap between the intact femur and your prosthetic shoulder. Head, I don't need to tell much about this. Size, choosing the head size is very important. Already has been highlighted. Never take a larger head. Always one size smaller. I'm sorry, something here. Plug in another something. Please, can you help me? So, these head gauges must be used and arrive at the correct size of the process. Now, trial insertion. You have RASP it. Now you know how, this is where you will get to know how far you can insert the process. Now the process is inserted, and now as I said, that is the intact bone you can see, and the center of the head also you can see. Now you have the measurement which I have taken earlier. To that extent you can insert the process. This gives you the exact axial seating so that at the end you don't have any soft tissue, loose or tension problems, and also there won't be any limb length discrepancy. This is one of the important steps. Now you measure this distance from the intact bone, proximal bone, to the shoulder of the process. That you have the choice of filling it with your bone, or if you want, you can just continue with the cement also, depending on the age of the individual. So now, canal hemostasis is very important. If you are doing a cemented arthroplasty, it has to be dry. So we use hydrogen peroxide soaked gauze. After washing it, insert this gauze tightly packed so that it gives a good bloodless feel for you to insert the cement. This is all manual. We don't use sophisticated fancy stuff. See, you have to at least, at the end you have to be cost effective. Most of the patients who come to us, they are not very rich people, middle class. So you can't think of having all those fancy stuff what we see in England and America. So you have to manage locally with what is available. I must tell again, with due apology to those who follow, who will keep saying that evidence-based medicine, it's always good to know what evidence-based medicine says, but at the same time, you must know what is practical also. For example, anybody says from Hyderabad to Tirupati, the best way is to fly. All of us know, but everybody cannot fly. You should have an alternate means of reaching that destination in a safe way. That's what I would like to impress upon you. Try to find out cost-effective, easy, safe solutions. You don't need to think of all the time evidence-based. A lot of junk will be there in journals also. Don't believe what is published in the journals. Don't blindly go for it. Please. See, so many articles I can show you, one favoring this, one saying useless. So how to believe? Until you wait until it gets established, it gets consolidated. Definitely something like, review articles will come and textbooks will come, latest editions. They will give the true picture of what is going to happen to that. Initially, don't take whatever ribbon gauze, and when the cement is ready to be inserted in the Dewey state, as I said, I go for manual, improvised cement gun like thing. I will show you how I do it. So the sister says we are ready because they are very well trained, our sisters. They will tell when the cement is ready to be inserted. At that time, I take away the ribbon gauze, And you see this feeding tube also too. If you don't put this feeding tube, which is connected to the suction, you cannot create a vacuum inside, and the cement, you can't push the cement in. Air locking will take place. So you have a feeding tube inside before you insert the cement. Here the cement was inserted. As you can see, what I do, of course in this picture I am not, it's not there. What I do is, I take a thin osteotome, straight osteotome, and keep the doughy cement over that, and insert the osteotome to the depth of the femoral canal, and push the cement with finger. It goes, just like it does the same job as your cement gun, but at a cheaper rate, and also as I said, it is in the doughy stage, you have no problem of the monomer gaining access into the systemic circulation. So cement has been inserted here. At this stage, we pull out the feeding tube, and now process is inserted. Now we know to what depth to insert this process. We have the measurement from the intact bore to the shoulder. To that extent, I insert this, and rest of the gap is made up by the cement. As I said, if the patient happens to be relatively young, you can think of putting graft also, bone graft also, because stem is being fixed distally with cement. Now process is reduced. You can see the reduced process. Some cement is being seen there, which is occupying the gap between the prosthetic shoulder and the femoral shaft. And I always do, if it is a hemiarthroplasty, capsulorrhaphy. You must have split the capsule in the beginning. That is re-sutured so that process gets some of that. And tension band, at this stage, you have the trochanter fragment. Always I find one big chunk of trochanter into which the abductor mass is attached, that can be brought back and placed over the intact femur, which is made raw, and then fixed it with my type of tension band wiring. I always use 2 screws, partly threaded cancellous screws, and then over that a tension band also. You can see this in the diagram here. You can see the 2 screws and the tension band. And then tensor fascial later closure and skin closure. And this is a patient soon after the operation, the same patient which we have been following. See the limb lengths, perfectly all right, version wise, everything is fine if you follow all what I have said. The postoperative protocol will be sitting in bed is allowed, and in bed exercise first post-op day. Second post-op day, ambulation with walker, weight bearing as tolerated. Third post-op, we inspect the wound. Fourth post-op, we discharge, suture removal at the end of 14 days. And this is the post-op X-ray. And see the patient sitting here in the post-operative when we go for ward rounds. And the same patient, when she came back for suture removal, see how happy she is. So for a successful surgery in a cemented bipolar, these 3 points are very important. Correct axial seating of the process, correct version of the process, and hip abductor restoration. These 3 are very, very important if you want to come out successfully. Axial seating, as I said, on the other side you would have seen, probably the top of the trochanter was matching with the femoral head there, so you have to recreate that here on the prosthetic side. That is how we judge the axial seating. Version, as I said already, the Tommy bar and the leg axis will help you. And abductor restoration, as I said, you can use the plate, you can use tension band, variety of devices, screws alone or wires, whatever you are familiar or comfortable with. Optional designs, long stems and calcar replacements, very rarely needed. Thank you very much.
Thank you, Dr. I V Reddy garu, about your excellent lecture delivery about role of frame in cemented bipolar arthroplasty. So please accept the small memento behalf of the TOSA Nizamabad branch.